This is Robert McMullen, MD. I'm a psychiatrist in New York who specializes in psychopharmacology and TMS, transcranial magnetic stimulation. I went to Georgetown Medical School and Columbia for psychiatry. I want to talk about the question of when to hospitalize someone who has a serious mental illness, especially depression. The main reason is if they are very suicidal. Even if there is 1 in 100 chance of them killing themselves, it's better to have them hospitalized so it doesn't happen and you don't have to worry about it. I made a mistake once that a patient came to me who had 3 or so previous hospitalizations when he became extremely suicidal, and then he would recover and do well for a few years, and he'd get involved with a new business, and then he might have the onset of a mild depression getting worse, and then the business would collapse. It was sort of sad. He was now in another agitated depression, extremely anxious, very suicidal, but was adamant he did not want to be hospitalized. I treated him very aggressively. And in a short time, the suicidal thinking was gone, and he was becoming just about normal in mood. He had moved in with his mother for the time period that he was in a bad depression. And then I get a call that he jumped out the window and died. It turned out that the family wrote a letter to me, and they were a little angry at me, and they wanted to tell me about this, so I did not do it again with anyone. The problem was that he was on something like 20 milligrams of Zyprexa, a fairly big dose, but that was a major part of his treatment. His mother had taken over giving him the medication, and it was really hard for her to give him 20 milligrams because it zonked him out. She gave it to him at bedtime, but it would really sedate him, and then he'd be a little sedated the next day. So she decided to lower it to 10 milligrams, not asking me, and in 2 or 3 days he was back in an agitated depression and jumped out the window from a high building. That patient I should have hospitalized, because you cannot rely on the family to watch the patient all the time and to give them the medication they need. It's hard to predict. I have a lot of very religious people, Hasidim, and when they marry, the marriage is usually arranged. So one family meets the other family, and it's usually arranged by a matchmaker. And they go out on 3 dates or 5 dates, and then they make up their mind. But before they decide on putting these two people together, they will investigate. One family will investigate the proposed marriage partner. And they find out all sorts of things, and if it's the young man, they talk to people that went to yeshiva with them, they talk to neighbors, they find things out. And also, each family is obligated to tell the truth about the person's past. Now, if you've been hospitalized, that immediately is a powerful signal, and makes it much harder to obtain a shidduch, a agreement to marry. So if I jump in and am aggressive with the medication so that the patient can stay at home and will be back to normal in a few weeks or more, that's an entirely different thing. The family can say, well, he's had some struggle with depression and he's on a little medication, and they'll tell him what the medication is and the dose, but he's done really well. That's completely different than having to tell the other family that you've been hospitalized. So in this group of people, I make an extra effort. If someone is severely depressed but not especially suicidal, that's a problem about whether to hospitalize them. I think it is often not that useful because once they're in the hospital, they'll be put on some sedating medication, and that's likely to make them less agitated and more functional and so on. But they don't really start people on things that would work over the long run, or they may put them on SSRI, serotonin medication like Prozac and so on, when actually the patient is a little bipolar and the family has a bipolar history. So that's not the greatest idea. It's sometimes better to treat them as an outpatient. Sometimes the patient is in so much pain that it's better to treat them and they in the hospital, and they really want to be in the hospital. I had one interesting fellow a long time ago, very nice, intelligent guy who had been an elementary school teacher all his life, and he went into these severe depressions where he couldn't function. It was really painful. After quite a while, we decided to do shock treatment, and we admitted him to the hospital, and within a couple of days his mood was up to normal or almost normal. When you go into the hospital, the fact that you're in a place where everything is taken care of, it really helps. They don't have to worry about preparing meals. They don't have to do anything except watch TV and go to group therapy. And they often have their mood lifted within a few days. So I admitted him twice when he had these severe agitated depressions. And then, of course, we didn't go through with the ECT. It seemed useless. But as soon as he went home, and he had an excellent relationship with his wife and kids, he'd go back into this severe depression, and then we finally admitted him, and despite his not getting very depressed, we went ahead with ECT, and it worked. He did not relapse in depression for quite a while after that, and he was on maintenance medication. It's a good idea to be on maintenance medication afterwards, and I especially like to use Lamictal, lamotrigine, and low-dose lithium because they have virtually no side effects, and they work. And they work especially in people that are a little bipolar, or maybe more than a little, but not manic depressives. And they work in atypical depression, people that have hypersomnia and they're rejection sensitive. If they have a romantic breakup, they might go to bed for weeks and sleep all the time. And for small rejections, that somebody gets a little mad at them at work or their spouse or a friend, and they'd only done something a little wrong and they were only a little mad at them, nonetheless, it'll be very painful, and they will think about it the rest of the evening. They also tend to have more depression in the evening and less depression in the morning, whereas the classic melancholic depression is just the opposite. They're extremely depressed in the morning, and as the day goes on, they may get less and less depressed. And the melancholic patient characteristically wakes up at 4 or 5 in the morning and is tortured because he or she can't fall back to sleep. So it's a difficult decision whether to be hospitalized or not. A lot of it depends on whether the psychiatrist is willing to be in daily contact on the phone to reassure and adjust medications, and maybe see the patient 3 times a week or something, really frequent, so that you really form a good bond and the patient becomes more optimistic that they will get better and more trusting of you. I found that it is much better if you've treated people and their family. I just had a 29-year-old man come to me because of chronic anxiety and especially depression, which is a little worse recently. And I treated his grandmother, who had occasional manic episodes but was chronically severely depressed, and she did very well. And then I treated his parents for mood disorders that weren't all that severe, but all 3 of them did very well, and they were very optimistic about me. And when he came in, he just accepted the things I said. He just didn't have a tendency to be resistant or argue about taking this or that. I didn't give him a huge amount of things. I think, mainly lithium and Lamictal, and I forget if I added any augmentation. But he will be easy to treat because he's going to be very cooperative on the treatment plan, that I will make the treatment plan with him. He's given a decision about whether to do this or that. Thank you very much.
Just another question. Can you force somebody to inpatient treatment?
Can you force someone into inpatient treatment? Yes, and you can usually do it if 2 physicians, they don't have to be psychiatrists, will sign a form saying that the person needs to be admitted. But even then, the hospital may want the patient to sign a voluntary form, because if 72 hours later the patient writes a note saying they want to be discharged, if they are there on an involuntary basis, then the psychiatrist has to go to court, which takes up half a day and interferes with his schedule, to keep the patient in the hospital. So they'd rather that the patient come in voluntarily, so then they can easily let him go when he wants to after 3 days. And it gives the patient more of a sense of control. It's kind of embarrassing to be there involuntarily. Usually the psychiatrist will only sign off on this if the patient is a danger to himself or others, that he's threatening violence a bit, or is possibly suicidal. I tell the family sometimes that the patient really needs to be admitted. They haven't been cooperative with medication. They're deteriorating. They may well end up homeless on the street. Well, I call that dangerous. It's a little dangerous over time. And I say, if he has threatened you in any way, or even scares you by getting up too close to you in your space so you are frightened, then I would embellish on that when the police come and when you talk to the psychiatrist in the emergency room to make him sound maybe a little more dangerous than he is. Because in our system, they give the patient almost too many rights. If he has a 10% chance of killing himself, the doctors may decide, well, we can't do this because it's not serious enough. And the law goes along with that too. But a 10% risk, I think, is too high. If I had a brother or a sister who was that deeply depressed, I think even 1% is not, is too much of a risk. Sometimes someone who has been really difficult to handle is transformed when they go to a psychiatric hospital or ward because they see all these really ill people around them. There's not as many depressed people in hospitals now because our medications work better. So there are more people with more serious illnesses like schizophrenia. And our patient with depression looks around and he says, wait a minute, all these people are really mentally ill. Why am I in here? And then he becomes more aware that he has to keep control of this mood disorder, and he may get a lot more compliant because he doesn't want to go through that again, and he realizes his illness is not so terribly severe as other people have. I had one lady 38 years ago as an inpatient, and she was repeatedly hospitalized for major depression, and she had sued a few people where she worked. She was a nurse, and she'd fall and hurt her ankle. She'd sue somebody, and she had a fair amount of money saved up. She wasn't that severely depressed, but she would threaten suicide, and she liked it there, and she didn't want to leave. So I used all sorts of arguments with her, and I pointed out that she was really being cruel to her dogs, that she didn't return home and take care of them. It didn't work. So finally, I arranged for her to be transferred to a long-term hospital, a state hospital, which is not too pleasant. Bare walls, not so many caretakers around. It's much more unpleasant. Being a nurse, and she had actually worked in a psychiatric hospital for disabled people. She did not want to do that. And as we got closer to sending her there, she decided to behave and to get herself prepared to go home. She did go home, and she did well at home. Sometimes you have to use that threat to induce people to get themselves together. I've seen a number of people who were hospitalized really because their psychiatrist just couldn't take it, that the patient was extremely depressed, painfully depressed, and was calling up frequently, and the doctor was really busy, and she or he knew that if this patient stayed as an outpatient, they would have to be on the phone continually and have a lot of trouble figuring out what medications to use, And it was just going to be a major interference in the doctor's day. So he or she would say, go down to the emergency room and be hospitalized. You really need to be hospitalized. And the patient was feeling so miserable that it seemed reasonable. And they went and got themselves hospitalized, even though they weren't suicidal. And some of them really regretted it later because they were embarrassed by the hospitalization, or they found it extremely unpleasant there, or they found it humiliating. It's a difficult decision about whether to hospitalize someone. The main reason would be the fear of them committing suicide. And some people just would not do it, or it'd be one chance in 1,000 or 10,000, because of their family, because of their religious beliefs. They were entirely against it. It is interesting that the depression itself makes you suicidal. If you give someone that's suicidal lithium, often the suicidality will evaporate even though they're just as depressed. I had a Catholic brother a long time ago who was chronically depressed. He was very happy with his life. He lived in a religious community. He was a teacher, and he was going to go up in the ranks and become a principal and so on, because he was smart and very well liked and did a good job. But he needed 80 milligrams of Prozac to stay completely normal. It was a big dose. Once in a while, we would try to lower it to 60, and immediately he would start having suicidal thoughts. He was a little depressed, not severely, but the suicidal thoughts would come, and it was just shocking to him because he loved his life. He didn't mind being celibate. It was completely against his Catholic religion to commit suicide. There's a lot of other people that would be affected, and yet he couldn't stop these suicidal thoughts. In many people, the suicidal thoughts are just caused by the depression. And as soon as we went back on the medicine, they went away, and he did very well. There may have been an evolutionary reason for the suicidality. The Eskimos, or Inuit, sometimes decided when they were very old that they were too much of a burden. It was hard to have enough food for everybody, and they would go out on an ice floe and let themselves float away and freeze to death. And it could be that thousands of years ago, it was an advantage to passing on your genes if, when a summer had been not so productive and you were beginning to starve as the late winter occurred and the spring was late, that some of the older people would get very discouraged and feel that they were a burden and would go out in the snow to kill themselves. I've read a number of books about Native Americans written by white people who were captured by the Indians and then became part of the tribe and wrote a book about all the details. When they returned to white society, sometimes they didn't know English that well, they would eventually write a book, like a travel book. And this lack of food later in in the winter was frequently described. There wasn't any suicides described, but I could see how it would happen. Anyway, this is Robert McMullen, MD, and I just spoke a little bit about when to decide to hospitalize someone.
Thank you.